Overview. Carbon dioxide is generated in the body as a metabolic byproduct. Carbon dioxide dissolves in the blood and is transported in the bloodstream until it reaches the lungs, where it diffuses into the alveoli. The alveoli are ventilated through an open tracheobronchial tree and a patent upper airway. Carbon dioxide can then be detected in the patient's expired breath. The measurement of expired carbon dioxide provides insight into important life-sustaining processes that include metabolic, circulatory, and respiratory activity. Capnography is the standard of care for monitoring the adequacy of ventilation in patients receiving general anesthesia. It is also used to monitor ventilation during procedures performed while the patient is under moderate or deep sedation. Capnography is increasingly being used to monitor patients who are receiving mechanical ventilation in intensive care units and to aid in the assessment and treatment of cardiac arrests. Before capnography was available, physicians relied on the physical exam, such as auscultation of the chest, to assess the adequacy of ventilation and proper placement of endotracheal tubes, and on arterial blood gas analysis to determine the partial pressure of carbon dioxide. Capnography allows for non-invasive and continuous monitoring of carbon dioxide levels and can provide valuable information regarding the metabolic, circulatory, and respiratory conditions of a patient. Although capnography is not complicated, the clinician must understand the principles of capnography and how the equipment works in order to interpret the information it provides. Definitions. Capnometry refers to the measurement and numerical display of carbon dioxide concentrations. Capnography refers to the graphic display of the exhaled and inhaled carbon dioxide concentration plotted against time. Colorimetric capnography is a qualitative method of determining the presence of carbon dioxide using a pH-sensitive filter that changes color from purple to yellow when carbon dioxide is detected. PaCO2 denotes the partial pressure of carbon dioxide in arterial blood. End-tidal carbon dioxide is the percentage concentration or partial pressure of carbon dioxide at the end of exhalation, normally 5% of atmospheric pressure or approximately 38 millimeters of mercury at sea level. Hypercapnia and hypercarbia refer to a greater than normal partial pressure of carbon dioxide in blood. Hypocapnia and hypocarbia refer to a lower than normal partial pressure. Indications. Capnography is used in the operating room to aid in the proper placement of endotracheal tubes and to monitor ventilation. Capnography is increasingly being used to assess the adequacy of ventilation and to monitor for hypercapnia or hypocapnia in treatment areas such as intensive care units, post-anesthesia care units, emergency departments and ambulances, endoscopy suites, sleep laboratories, and cardiac catheterization laboratories. Carbon dioxide detection is frequently used during cardiopulmonary resuscitation to aid in determining the proper placement of an endotracheal tube and to assess the effectiveness of resuscitation efforts. While pulse oximetry is a good method for the assessment of oxygenation, capnography provides more direct information on a patient's ventilatory status. Capnography is particularly helpful in patients who are receiving supplemental oxygen, during which a normal hemoglobin oxygen saturation can be present in spite of marked hypoventilation. Contraindications. There are no contraindications to the use of capnography, provided that the data obtained are evaluated in the context of the patient's clinical circumstances. It is generally safe to use capnography for the monitoring of all patients. Principles of operation. Capnography is based on the concentration of carbon dioxide in a sample of exhaled gas throughout the respiratory cycle. Because of the chemical properties of carbon dioxide, a variety of techniques can be used to measure its concentration. Infrared absorption spectroscopy is typically used in clinical practice. Infrared light can be passed through a sample of gas to an infrared detector. As the concentration of carbon dioxide increases, the intensity of the light that reaches the detector decreases. Carbon dioxide gas strongly absorbs infrared light with a wavelength of 4.3 microns. At this wavelength, there is minimal interference from other gases that may also be present, such as water vapor, oxygen, nitrous oxide, and inhaled anesthetic agents. There are two types of capnograph devices. Mainstream capnographs use sensors that are placed directly into the breathing circuit of a ventilator. Side-stream capnographs draw a sample of gas away from the breathing circuit to a separate gas sensor. The response of a side-stream device to changes in carbon dioxide concentration is delayed by a few seconds, since the gas must travel through the sampling line before it can be analyzed. However, in patients who are not intubated, side-stream capnographs can be used conveniently with a face mask or nasal cannula to monitor respiration. Nasal cannulas and face masks that feature integrated CO2 sampling are commercially available. You can modify standard face masks by attaching the sampling line directly to the orifice of a mask, or by securing the sampling line inside the mask. Take care that the orifice does not rest against the patient's skin to avoid occlusion of the flow of gas into the sampling line. Alternatively, you can place an integrated sampling nasal cannula underneath a face mask. Data interpretation. A normal capnogram shows a regular, nearly square waveform that oscillates at the same frequency as the patient's respiratory rate. During inspiration, the capnogram should be at 0 as the patient breathes in fresh gas. When the patient starts to exhale, the first gas exhaled will be from the anatomical dead space and will contain little or no carbon dioxide. However, the concentration of carbon dioxide in the exhaled gas will rise rapidly and plateau as the alveoli begin to empty. As exhalation proceeds, the concentration of carbon dioxide remains high and increases slightly. The peak concentration reached at the end of exhalation is the EtCO2. As the patient begins to inhale again, the capnogram falls rapidly to 0, indicating the absence of carbon dioxide in the inspired gas. In patients who are not intubated, the samples of the exhaled gas are mixed with the surrounding atmosphere and fresh gas flow, diluting the concentration of carbon dioxide. As the side stream catheter is moved farther away from the patient's airway, the EtCO2 value will decrease progressively. Although the EtCO2 of a patient who is not intubated represents only a qualitative indicator of ventilatory status, the patient's respiratory rate can still be determined from the waveform of the capnogram. Proper use of capnography. In patients who are not intubated, place the side stream sampling catheter close to the patient's airway, using either a face mask or a nasal cannula. Capnography should be started before treatment is begun, so that satisfactory baseline tracings of the patient's spontaneous respiration can be obtained and correct operation of the capnograph can be confirmed before any procedural sedation is administered. Any change in respiration can then be assessed relative to this baseline. In patients undergoing endotracheal intubation, capnography helps to show that the trachea, and not the esophagus, has been successfully intubated. However, if the stomach is insufflated with air that contains carbon dioxide, or if the patient has recently swallowed a carbonated beverage, the capnogram might transiently show the presence of carbon dioxide, even if the endotracheal tube has been erroneously placed in the esophagus. A series of successive, steady, normal capnographic waveforms must be seen to rule out esophageal intubation. In addition, a capnogram tracing indicates gas exchange and does not inform the clinician about whether the endotracheal tube is positioned properly. For example, whether it is in a bronchus or in the oropharynx. Capnography is useful for the measurement of the ventilatory characteristics of intubated patients, and it may reduce the need to measure arterial blood gas. Common problems and limitations. Capnography is valuable for monitoring a patient's respiratory status. However, it is important to be aware of circumstances that may affect its reliability and to be able to recognize and interpret abnormal waveforms that may result from pathologic features or from technical difficulties. Capnograms must always be interpreted in conjunction with other physiological variables, and clinical judgment is important. Loss of the capnographic waveform may be caused by apnea, disconnection of a ventilator circuit, occlusion or dislodgement of an endotracheal tube, or occlusion or disconnection of the sampling line. Waveforms that do not return to zero during inspiration indicate rebreathing of carbon dioxide. This can occur if the carbon dioxide absorber in an anesthesia machine is chemically exhausted, if a valve in the ventilator circuit is not functioning properly, or if the flow of fresh gas is insufficient. An elevated baseline can also be seen if the device is calibrated incorrectly. Decreases in EtCO2 can be due to hyperventilation, pulmonary embolism, cardiac arrest, sudden hypotension, hypovolemia, hypothermia, leaks in the sampling system, or a partial airway obstruction. Increases in EtCO2 can result from hypoventilation, rising body temperature, bronchospasm, adrenergic discharge, release of a tourniquet on an extremity, or ventilation of a previously unventilated lung. Shallow breathing transiently lowers EtCO2 because of dead space ventilation, but EtCO2 rises again when full gas exchange occurs. Cardiac oscillations result from the transmission of cardiac movements to the lungs and airways. These oscillations are usually seen when either respiration is slow or the tidal volume is small. Such oscillations suggest inadequate ventilation, and a capnogram with prominent cardiac oscillations suggests the need to initiate assisted or mechanical ventilation. Although capnography provides a quantitative measurement of EtCO2, it is not as accurate as blood gas analysis for the assessment of the partial pressure of arterial carbon dioxide. A gradient exists between the partial pressure of arterial carbon dioxide and EtCO2. This gradient increases as the dead space volume increases. In disease states characterized by increased dead space and ventilation-perfusion mismatch, such as emphysema, an arterial blood gas analysis is necessary for an accurate determination of the partial pressure of arterial carbon dioxide. Troubleshooting. Artifacts should be the last explanation for changes in critical values. Therefore, when a low or high carbon dioxide reading is obtained, a physical assessment of the patient must be performed before the assumption is made that the values represent equipment malfunction. If the patient appears to be clinically stable, consider the possibility of either leakage or occlusion of the sampling system. Make sure that the side stream sampling line is well connected to the circuit and to the water trap on the capnograph, and that the water trap is firmly attached to the capnograph. To quickly test the integrity of the sampling line and monitor, breathe into the sampling line. A waveform confirms proper sampling, although small leaks diluting the sampled gas may go unnoticed. The sampling line or water trap may become occluded with condensed water. Disconnecting the sampling line and flushing it with air from a syringe can sometimes clear it, but it may be necessary to replace these components. Elevating the side stream sampling line above the ventilator circuit helps prevent the entry of condensed water. A humidity barrier is also useful, although this will increase the response time of the capnogram. Complications. Although capnography is generally safe, its use still carries a small risk of adverse events. Mainstream analyzers may introduce an excessive amount of dead space into the ventilator circuit. Older generation mainstream sensors use heat to inhibit the condensation of water vapor and prevent falsely high carbon dioxide readings. But this increases the risk of burning the patient's skin. Also, to reduce the risk of accidental extubation, caution must be taken to minimize the amount of additional weight placed on the airway. Summary. When used correctly, capnography is a potentially life-saving tool. Healthcare providers need to be aware of the indications, benefits, and disadvantages of capnography and must be able to interpret the information it provides. With proper training and instruction, clinicians will find capnography to be an invaluable tool for monitoring ventilation.